Thanks for inviting me to participate in this 4th International OCTA Congress. I wish to discuss with you about OCTA CNV diagnosis and principal artifacts. My disclosure: as you know, standard fluorescein angiography shows normal retinal vessels. OCTA shows superficial and deep capillary plexuses with qualitative and quantitative values. All vessels are hyperintense on these plexuses. And below IPE, because shield effect, OCTA shows that all choroidal vessels are hypointense. OCTA gives a correct diagnosis, but we have two concerns: layer segmentation and projection artifacts. We observe projection artifact of retinal vessels from superficial and deep plexuses on IPE, and on angiomed OCTB, vessels are hyperintense and not hyporeflective as with structural OCTB. With OCTA, we have also some new signs of CNV, such as active versus quiescent criteria and quantitative values with good sensibility, whatever the algorithm. Active criteria as shape, pattern, anastomosis, vessel termini. Quiescent criteria as linear, mature, rifled vessels or deep tree aspect. Here are some clinical applications. We have an example of conventional multimodal imaging. On FA, moderate leakage. On ICG, no defined network. PD or vitelliform lesion on OCTB scan. OCTA will bring immediate and striking diagnosis of CNV presence, confirmed by angiomed OCTB. The hyper signal is present even in death. On the zoom, you can see DC wheel network. Let's look at a second case: moderate leakage on FA, uncertain network on ICG, PED or advanced vitelliform lesion on OCTB scan. Here, OCTA doesn't detect any CNV. Confirmed by angiomed OCTB scan, the hyperintense lesion has a dark shadowing. And on the zoom, attenuation of signal confirms absence of neovascularization. But it is not always that easy. Here, we have limited leakage on FA, no network on ICG, progressive accumulation on OCTB. And if we have no fluorescein angiography, on this OCTA, we observe a hyperflow signal. Is it an early proliferation of CNV? We try, therefore, to separately analyze the superficial and the deep capillary plexus to see if there was some correspondence between the shape of the lesion and the aspect of the two retinal capillary plexuses. In fact, the combined structure is derived for their fusion with a similar shape of a hyperintense structure found at the outer nuclear layer. The hyperreflective intraretinal deposits may mimic perfused vascular structure. It is an artifact. In this other case, we consider a CNV aspect with metamorphopsia and macular edema on OCTB scan. On OCTA, we observe an hyper signal on IPE segmentation, but it is DCP projection, and on DCP section, you have dilations of capillaries. The residual venular occlusion is confirmed by fluorescein angiography. A last case with different OCTA instrument, base dystrophia with metamorphopsia from 2 days, good visual acuity. We observe on FA staining, on ICG no defined network, on OCTB homogeneous hyperreflective material in front of probe with atrophic areas on OCTB with also subretinal fluid. With full spectrum OCTB, we have at the center a voluminous hyper signal with some branching. It is fibrous CNV, and at the borders we have tiny capillaries, but it is due to loss of shield effect on these atrophic parts of IPE. The choroidal vessels become hyper-intense. With split spectrum OCT, it's also difficult to know if it is persistence of recurrence. On the left, the hyper signal is between Brock membrane and IPE. It is CNV. On the right, in all these different localizations, the hyper signal is deeper than Brock membrane. It isn't CNV. The colorized OCT-B scan helps us to see CNV and eliminates artifacts. With swept source OCTA, you can see the cross helping to distinguish CNV from artifact. Here, the hyperflow signal corresponds to residual CNV. And here also, you have CNV in inferior. But here, the hyperflow signal corresponds to choroidal vessel at nasal side or at temporal side. In conclusion, so the game had changed. No injection, no side effect. But we have to perform a careful segmentation to identify the presence and the type of hypersignal on OCTA, to recognize backshadowing on OCT-B scan, the eventual loss of shield effect, the other artifacts related to tracker and segmentation thickness, and then avoid potential diagnostic pitfalls. Thank you, and please save the date at